Hi, everyone, and thank you for joining us for our latest policy briefing focusing on rural women's health and current opportunities for innovation and investment. I would like to extend a thank you to Healthy Women's Corporate Advisory Council for sponsoring today's briefing and for their ongoing support of our mission. For those of you who do not know me, I am Beth Battaglino, President and CEO of Healthy Women. Healthy Women is the leading independent nonprofit health information source for women. For more than 35 years, we've been dedicated to educating midlife women so that they can make informed health decisions, advocate for themselves, and prioritize their health and wellness. At Healthy Women, we understand that women's health is about much more than breast and reproductive care. It's a whole person health from head to toe. Women are often the primary caregivers, not only managing their own well-being, but also looking after the health of their children, partners, and aging parents. Too often, they delay their own care to put others first. These challenges are even more pronounced in rural America, where access and resources are limited, and the burden has only grown heavier in recent times. In today's briefing, we have brought together leading experts and advocates to explore the urgent health challenges facing women in rural communities and highlight innovation solutions that are improving access to care and health outcomes. We'll discuss strategies for scaling and sustaining these successes. We're going to discuss how emerging advancements are driving meaningful progress. And we're going to examine the economic case for investing in rural health innovation. Martha Nolan, Senior Policy Advisor to Healthy Women, will be moderating today's conversation and will introduce our speakers. Martha, over to you.
Thank you, Beth. Welcome, everyone. Thank you for taking the time to join us today for this important conversation. Women's health in rural America faces significant challenges, including limited access to healthcare facilities, a shortage of specialized providers, and a long travel distances for essential services like prenatal care and cancer screenings. Economic barriers, lack of insurance, and inadequate transportation further complicate timely and consistent care. Additionally, rural communities often struggle with higher rates of chronic disease and mental health issues, while stigma and privacy concerns can deter women from seeking help. Women in rural areas are disproportionately burdened by geographic, economic, and provider shortages challenges. For example, only about 6.4% of U.S. obstetricians and gynecologists practice in rural settings. Rural women are more likely to travel farther for care. Less than half live within 30 minutes drive of a hospital offering prenatal services. Maternal health outcomes highlight stark disparities. Rural counties, see maternal mortality rates that are 60% higher than urban areas. And among Black women living in rural areas, maternal mortality is significantly higher than for white women in rural areas. Preventive care and chronic disease burdens also show gaps. Rural women report higher rates of conditions like obesity, diabetes, and smoking, all of which increase risks for leading causes of death like heart disease and cancer. Finally, socioeconomic barriers are significant. All of these factors combine to create an environment where rural women face delayed diagnoses, fewer options for obstetric and gynecologic care, and worse health outcomes across the board. So we're here today because these challenges are not inevitable. Improving women's health outcomes in rural areas requires a multifaceted approach that addresses access, affordability, provider shortages, and social determinants of health. So the speakers you will hear from today are doing all of that and more. First, you'll hear from Christine Hamp, president of the National Health Grange, who will discuss their advocacy work to ensure that all communities have access to quality, affordable, and reliable health care. The National Grange is the nation's second oldest lobby, founded in 1867 to give voice to rural families and agricultural communities. Hamp comes from deep rural roots. A fourth-generation Grange member, she grew up on her family's dairy farm in Monroe, Washington, where her great-grandfather homesteaded in the early 1880s. That upbringing has shaped her enduring commitment to the resilience and well-being of rural and agrarian life. After more than 31 years in state and local government, the vast majority in the fire service, Christine retired in early 2023 at the rank of Division Chief. She was also serving as a Type 1 Finance Section Chief for the Pacific Northwest Team 2 Incident Management Team, with which she responded to major wildfires across the western U.S. After Christine, we will hear from Dr. Joyce Knestrick, who is a professor at the George Washington University School of Nursing. She is the past president of the American Association of Nurse Practitioners. She also practices as a nurse practitioner in a community health center located in rural Appalachia, caring for low-income and underserved populations. Knestrick's research is focused on health and access to care for low-income and rural populations, particularly women. She will help us understand the current barriers she is witnessing in her work in West Virginia and how they are emblematic of those affecting communities nationwide and strategies that are improving health outcomes in her community. After Dr. Knestrick, Ariana McGee, the founder and CEO of Navigate Maternity, will speak. Ariana's organization is working to close the gaps that exist in maternal health and reduce maternal mortality by reaching women in communities that are struggling to access quality care. And finally, Elizabeth Wallace, the Executive Director of the Mobile Healthcare Association, will speak about innovations in access to care via mobile health clinics and how we are reaching vulnerable communities to close gaps in access to quality care. Before we hear from our panel, I would like to remind all that are participating today to put your questions in the Q&A box, as there will be a Q&A session after all of our speakers have presented. I would now like to welcome Christine Hamp to begin her talk. The floor is yours.
Thank you, Martha. It's an honor to join you all today and to represent an organization that has stood shoulder to shoulder with rural Americans for nearly 160 years, the National Grange. For those who don't know us, the Grange is a community-based, nonpartisan organization founded in 1867 to bring people together in service to their neighbors, their communities, and their country. While our roots are in agriculture, our reach extends far beyond the farm. Today, our members include doctors and nurses, teachers and small business owners, elected officials, firefighters, and yes, farmers and ranchers. We are the social and civic fabric of rural America, nearly 1,400 local chapters strong across 36 states. Our organization is multi-generational. I'm a fourth-generation Grange member myself. At local Granges, you'll find children, parents, grandparents, and great-grandparents learning and serving and leading together. That continuity, that connection across generations is what keeps communities strong. The strength of our mission also shines in the number of our members who reach 60, 70, and yes, even 80 years of consecutive membership. I presented an 80-year award this past weekend. That kind of loyalty simply doesn't exist anywhere else. From the beginning, women have had equal status and have been at the heart of the Grange. And through their courage, their compassion, and leadership, they remain the heartbeat of America's rural communities today. Through my nearly 30-year career in the fire service in my home state of Washington, I understand the grit, responsibility, and leadership that women in rural America demonstrate every day. Rural women are often the caregivers, breadwinners, small business owners, farm and ranch partners, and volunteers who keep their towns running. Yet they're also the ones most affected when the systems that support health and well-being begin to crumble. That is why the National Grange continues to advocate fiercely for rural women's health, because when rural women thrive, rural America thrives. First slide, please. Earlier this year, we released our 2025 Rural Health Report, highlighting the widening gaps that threaten the well-being of rural Americans. Almost every rural health issue can be traced to one root problem: lack of access. In the past 2 decades, more than 180 rural hospitals have closed, and over 700 more are now at risk. For millions, that means choosing between care and cost, between treatment and travel. Next slide. In maternal health, the crisis is staggering. Over 2.5 million women of childbearing age live in areas without adequate prenatal or maternal care. 2/3 of rural counties lack even one obstetric hospital. More than half have no OB/GYN services at all. Imagine facing a pregnancy complication and having to drive over 60 miles, more than an hour, to find help. That is the reality for too many women in rural America today. The same story plays out in cancer care. Over 60% of rural counties lack a single oncologist. Cervical and ovarian cancers, highly treatable when caught early, often go undiagnosed because screening and specialists are out of reach. Access to preventive care is also declining. Rural Americans are more likely to die prematurely from heart disease, cancer, stroke, and respiratory illness, not because these diseases are worse in rural America, but because care is harder to get. The Inflation Reduction Act caused pill penalty makes matters worse by allowing pill-based treatments to come under government price controls years sooner than their injectable or infused counterparts. This unintended result is a disincentive for developing or maintaining medicines in pill form, the very form that's most accessible for patients, especially in rural areas, and pushes innovation toward infusions, requiring time, travel, and access to hospitals that many rural patients simply don't have. If you must drive hours to receive a treatment that could have been taken from your own kitchen counter, that's not a medical system serving you, it's one failing you. The Grange urges Congress to fix this policy. Access should not be limited by distance. Next slide, please. The Grange has long been a champion of public health and vaccination. As one of our members once told me, we immunize our livestock to keep them healthy. Why wouldn't we do the same for ourselves? Yet rural vaccination rates still lag behind urban areas, with some counties reporting childhood rates below the 90% threshold for herd immunity. Local pharmacies, clinics, and mobile health units are critical for closing that gap, and we support continued federal investment in those programs. But no discussion of rural health is complete without addressing mental health. Suicide rates in rural counties are 60% higher than in urban areas, and 65% of rural counties have no psychiatrist at all. In 2021, the Grange partnered with Rural Minds, a nonprofit dedicated to confronting the stigma surrounding mental illness in rural America. Together, we've launched programs that give communities the language and tools to talk about mental health, not with shame, but with compassion and courage. It is also important to remember that good health starts long before you walk into a clinic. It starts with food, housing, and connection. Nearly 1 in 5 rural counties is classified as a food desert. In too many towns, the only easily accessible grocery options are gas stations or dollar stores. That leads to higher rates of obesity, diabetes, and hypertension, not because people don't care about their health, but because their choices have been limited. Broadband access has also become a health issue. Without reliable internet, telehealth is impossible. Consider this. Diabetes is 17% more common in rural America, yet many patients can't send glucose readings to their doctors because their devices rely on internet connections they don't have. As one nurse in Alabama told us, some of my patients still manage their blood sugar by how they feel. That is simply unacceptable in 2025. We support universal broadband access through fiber, satellite, or any effective means, because in the modern world, connectivity is care. Last slide, please. The Grange supports a number of legislative and regulatory solutions for addressing these issues that I hope we'll touch on more during today's discussion. So I'll close with this. Rural Americans and rural women especially are strong, resilient, and resourceful. But resilience should not be mistaken for invulnerability. The future of rural health depends on collaboration between government, providers, and community organizations like the Grange, all pulling in the same direction. Thank you, and I look forward to today's discussion. Martha, back to you.
Thank you, Christine, for all of the work that you do on behalf of rural patients and their families across our country and how you are addressing those challenges through the Grange. I'd like to now turn the program over to Dr. Joyce Knestrick to help us understand more about the access to care challenges in rural communities and how she and the providers like her are working to deliver care to their patients.
Thank you very much, Martha, and thank you for setting the stage, my prior speaker, really to set the stage for when I'm going to try to bring it home to what it's like to be a provider and a patient in a rural health setting. Next slide. So what we know is the gap in mortality rates in rural areas has been widening. So when we look at the difference between rural and urban mortality rates from natural causes, we see it widening in the rural areas. 25 years ago, natural cause or disease-related mortality rates were similar for working age adults in both rural and urban areas. However, by 2019, natural cause mortality rates for rural residents of prime working age between 25 and 54 was 43% higher than those living in urban areas. In the clinic where I practice, we see patients under the age of 65. So we're really hitting that 25 to 54 year age population and trying to keep them from having the problems that will set them up for the higher mortality rates later on. Next slide, please. So that growing disparity reflects both an improvement in urban health and a decline in rural health, which has negative implications for rural families, communities, for employment in rural areas, and for the rural economy. So rural community residents died from the top 5 causes of death more frequently than urban county residents. So cancer, heart disease, unintentional injuries, COPD, and other lung diseases, and stroke. Many of these deaths are preventable. Next slide, please. Rural residents are often encounter barriers to healthcare, as our first speaker mentioned, that limit their ability to obtain the care they need. So access to healthcare implies that healthcare services are available and obtainable in a timely manner. But even when there's an adequate supply of healthcare services in a community, other factors may impede. And as she talked about, things like income, education, food, environment, transportation, housing, the community itself, and race and ethnicity can all play a part in the rural social determinants of health that we look at in our populations. Next slide, please. So, for instance, to have access to healthcare, rural residents must also have a financial means to pay for services such as health or dental insurance that is accepted by the providers in their area, which is also a key component. A means to reach services such as transportation. Remember, in a rural area, everything is located at a distance. Even though I live in a small rural community, it takes me 10 miles to get into the next gas station or grocery store. So if you think about that time that it takes to travel a distance, and many people are even in larger food or access deserts. So they may even have to take time off work to utilize services, which can be very demanding for people to do that. And they have to have confidence in their ability to communicate with healthcare workers. And I find that that ability to communicate either in person or over the phone or over the internet can also be very disrupted due to access issues. And trust. They want to really have trust. It's very important in rural areas that they can feel they have trust with the providers, but with the services, and that their privacy will not be compromised. And they have confidence. They need to have confidence that the care that they receive will be quality care. So we know, again, that education, access, and quality are important, healthcare and quality, neighborhood and built environment, and social and community context are important, and economic stability are important for all communities. So at our community health center, we take into consideration all of those attributes that we're looking at for building a healthy community, and what kind of services do we need to provide in order to maintain the health of the populations that we serve. Next slide. Because we know that barriers to unmet healthcare needs results in unmet healthcare needs, a lack of prevention and screening, as she talked about, our first speaker talked about preventing problems before they occur, challenges in treatment of chronic illnesses, and a reduced lifespan. So while access to healthcare does not guarantee good health, access to healthcare is critical for a population's well-being and optimal health. So we have to really look at how it impacts the health of people living in the community. It's really important for women because we know that the average age of death for women in 4 out of 5 rural counties falls below the national average of 81.3 years of age. Next slide, please. So Medicaid funding is really crucial for sustaining rural healthcare systems, and that includes hospitals, clinics, and community health centers. So in the community health center where I practice, we take both Medicaid and we have patients that we call them our patients. We're sort of their insurance, but they fall below or above, I guess, in the income to get to qualify for Medicaid, but they cannot afford their own health insurance. So a strong relationship really exists between Medicare coverage levels and financial viability of rural hospitals and providers. Medicaid's expansion is also associated with improved financial performance and sustainability, and lower likelihoods of closure, especially in rural markets and counties with large numbers of uninsured adults before Medicaid expansion. So we had large numbers of uninsured under Medicaid expansion in the 2 states we serve. We saw more patients who were able to come on Medicaid, sometimes just briefly, because we were then able to get them services that we needed to get them in shape to go back to work, and many of them did, and then went off Medicaid altogether. And then we have a group that still were not eligible to receive Medicaid that are still, but we're still not able to afford insurance of any type, even under the plans. And so they were able to use our clinic services as their coverage area. So you could see the differences. Nearly 1 in 4 people in rural areas have Medicaid coverage. And like I said, it really makes an important contribution to the clinics and to the hospitals, rural hospitals that are serving them. Next. So about 50% of rural hospitals operate with negative margins, and further reductions in Medicaid funding would force the facilities to reduce or eliminate essential services, would cause them to delay much needed equipment upgrades. And so when you have equipment, you have to keep it upgraded, or you have to keep it in line with standards. And sometimes if you don't have the ability to do that within your clinic, you have to stop using that equipment and send people out, which is also a burden. And some hospitals have already and may need to close their doors entirely. Rural hospital closures would leave many residents without nearby healthcare access, forcing them to travel for long distances between basic treatments and for emergency care. And so as a result, many patients in my area will forego preventative or routine care, and that leads to a higher utilization of emergencies services, which then increase costs and also increases a larger burden to the healthcare system. Next, please. So rural hospitals are the, oftentimes we don't think about it in economic terms, but rural hospitals are the largest employers many times in rural areas. So when they close, this creates further economic challenges for individuals living in rural communities. And as our Secretary of Health and Human Services said, rural hospitals aren't just providers, they're often the largest employers. When they close, pharmacies, stores, and entire communities collapse. That's why preserving rural hospitals is so critical. Next, please. Next slide, please. So that being said, I want to give you a little story about Amber. She's it's not her real name or her real age, but she is a patient who comes to our clinic. Since heart disease and cancer are the #1 cause of morbidity and mortality in rural populations, although in some places in rural areas, lung disease still remains #1. I want to talk about Amber because she recently came to our clinic to establish as a new patient. She had a history of mild COPD and atrial fibrillation. She was followed in a clinic that was run by a rural hospital about 2 hours drive from our clinic, but their funding is reduced and services for her were no longer available there. Amber is a worker. She works 2 jobs, but neither is considered full-time. And she was not offered any health benefits where she is employed, and she's not sure she could even afford it. Her medication costs are really high, and she has custody of 2 of her grandchildren that are middle school aged. She has never smoked, but says, I've been around smoke all my life. She works as a housekeeper and in a fast food restaurant. Public transportation in her area does not exist. I think there's 1 Uber driver in that town, and she has to use her gas money wisely, mostly to get to work. She was seeing a specialist for her atrial fib, but the provider no longer takes the Medicaid card. And one of the anxieties that Amber has the most is that she'll go over income from working her 2 jobs and then lose her medical card, which would put her at further risk. Her car is not reliable. She actually had a neighbor bring her in for this initial visit, and she worries what she will do if she was sick enough to have to visit the tertiary care hospital, which is about 3 hours from where she lives, and she would have to take a day off work just to go there for care. Although we can assist her with some telehealth follow-up, she really has limited access to the internet, mostly at work and at the library, and she does not always have cell phone access. So she has a paid cell phone, and when her data runs out, she has to wait till she can afford to reload it. her main concern really is about her grandchildren because she knows that she's at risk for having a heart attack or a stroke, and she has no other extended family that could help care for those children. If she loses her Medicaid card, she won't be able to pay for her blood thinners, inhalers, and cholesterol medicine, which increase her risk for stroke. And she was also told she may need a pacemaker, but she no longer is able to see that from a provider, and we can't get a record of that. The most disturbing thing that recently happened with Amber was that she had a shingles in her eye, which is considered a dermatological emergency. When she went to the, we told her to go immediately to the emergency room because we were concerned that she could lose vision in her eye. The ophthalmologist on call turned her away due to her Medicaid card. And this is one example of even the changes in Medicaid can impact a person. Fortunately, we were able to talk to that ophthalmologist between the ER physician and myself, had a three-way call. We were able to order medications and set up a protocol to treat her eye. And we also have an eye clinic scheduled in a few months so she could follow up with the ophthalmologist there. So we may be able to send our mobile unit to her area if there are more patients that start to need care in that access area, but it's really on the border of our reach. And so will be a little bit difficult for us to send the mobile unit there, but we should be able to work with other mobile units in that in the area to coordinate care. And I'm excited that one of our speakers is going to talk about mobile units. So that's a story about Amber, and she's pretty typical of many of the patients that we see in our community clinic. Next slide. So lack of access to care, the elimination of Medicaid services has devastating consequences, not only for individuals, but for the entire community. We have been working on several strategies and innovations to help with this. In our clinic, we use telehealth services. We use the telephone, which I call early telehealth. But, we do have telehealth available with screen if the patient has contact with internet reception. And we use a mobile unit. And I won't talk much about that since we have a speaker talking about mobile units, but we can offer some comprehensive care. We do have some limitations with mobile units. And then just like with our eye clinic, there are ways to either bring patients to clinics or there are ways to bring providers to the patients, which would probably work better that way. So like we do with our ophthalmology clinic, it may be possible for us to work on a cardiac clinic or something that we see as necessary. Something that's lacking in the community that we really need to bring services. So we're always working on new innovations to help bring care to our rural communities. Thank you very much for letting me share my story about my patient, Amber.
Thank you, Dr. Knestrick, for sharing your work and all that you were doing in Appalachia. That was powerful. We will now learn more about work being done to support women and communities in maternal health space and what innovations are advancing to help save lives now. So I turn the mic over to Ariana McGee of Navigate Maternity.
Thank you so much, Martha. And thank you so much, Dr. Joyce. Your story was amazing. Thank you all so much for being here. I am the founder and CEO of Navigate Maternity. We are a tech-enabled medical device company, and we focus on improving prenatal and postpartum outcomes for moms. I started this company because I am a mom. My husband and I have four kiddos, and we had four kids in 4 years. So our kids are now 7, 6, 4, and 3. And at starting the company, very quickly, I identified that there were some real challenges in moms accessing healthcare, me personally being one of them. My husband and I had our third child during COVID, and I was a high risk mom. I wasn't being touched. And that was the first time that I realized that there are gaps. And it was that experience that was the spark for Navigate Maternity. But It turned into a flame when I almost died in childbirth with our fourth. My husband and I were having our fourth child in 4 years. I was a high risk mom. I encountered a very tired on call doctor who tried to send me home. And through advocating for myself, through having my mom, my husband, who was an orthopedic spine surgeon, we were able to advocate, and I finally was able to get the healthcare that I needed. But I almost died. And in fact, when my doctor finally was able to get to our hospital, they opened me up and uncovered that I had a uterine window or a thinning in my uterus so thin that you could see my daughter's hair. I was about to rupture. And so that was the key that let us know at our here at Navigate that we needed to do something and we needed to do something now. Next slide, please. Next slide. So this is our team. You all have now met me again. I'm a mom of four, but I've also been in the medical device space for over 13 years. Worked at a multitude of different companies, all the way to heading U.S. market access at a large medical device company. And our COO, Thea James, has been in the healthcare space also over 13 years, coming from the payer side of the business. And Dr. Alicia Harris, who is our Chief Medical Officer, Vice Chair of Indiana ACOG, was recently named IU's or Indiana University's a Women Health Physician Leader. So, we've got a great team on our side as we've brought our solutions to market. Next slide. So let's revisit the problem. The US has the highest maternal death rate of any high resource nation in the world. Black women like myself are dying 3 times our national average, despite socioeconomic background. And third, about 50% of rural counties lack OB services. We have these large maternal care deserts, and about 60 of those moms are about 60% more likely to die from those complications. But this is the stat that always sticks out to me. Per the CDC, at least 84% of these deaths are preventable. So we understand what mothers die from, right? We understand the how, but we don't understand the why, right? Next slide. So that leads me and led our team to identify 4 key clinical gaps. Number one, a mother, especially in a rural area, is touched about 14 times, and these are snapshots. That drives reactive care, right? We're doing something once we know something versus preventative care. Lastly, social determinants of health. And this is such an important piece. Rural moms often experience all of these issues around transportation, housing, food, access to healthcare. And all of those then are compounded by implicit bias. So, as Dr. Harris on our team often says, how can we replace that subjectivity with objective data? Next slide. And it's a problem that we have to solve now, right? This is a $25 billion problem each year, and it is currently growing. And all of us as hospital systems, payers, and innovators, providers, and patients, we want to solve it now. Next slide. So that leads me to what we've created here at Navigate Maternity. So we've created the infrastructure for maternal care. It is a turnkey system that combines FDA-cleared devices, wraparound services, and technology so that we can empower moms and care teams with the data they need to intervene before a catastrophic event takes place. Next slide. So all of this is underpinned by our technology. Our technology is called Navigate Her, which is our app. It's currently live on the App Store as well as the Google Play Store. And then we have our back-end portal called our Navigate Pro platform. This is where our care teams, community partners can join in and be able to identify and see data so that they can intervene on mom's behalf, whether that be clinical data or social determinant of health data. Next slide. And what we identified was that as we were, launching Navigate Maternity and growing, that as we first started with our Navigate 180 kit, which was our hypertension kit. And that, helped to address some key issues around blood pressure, which can lead to issues around stroke, hemorrhage, and things of that sort. With the feedback from our care teams and from our moms, we then started to launch lactation, compression garments. And so now we support moms from diagnosis all the way through postpartum. And then again, wrapping it around with education as well as the tech to be able to track the data. Next slide. So this really kind of lays out the traction, right? So we launched back in Q4 of last year, and we launched in Indiana and Kentucky. We went live with those technologies as well as our Navigate 180. In Q2 is when we launched our breast pumps. We also launched a podcast, which was super fun. We've got a lot of great feedback. And then we also launched an educational library. In Q3, in less than a year, we have 61 active prescribers in Indiana currently prescribing our technology. We've partnered with WIC, which is now known as Coaction, as well as two HRSA sites. So we're contracted with the HRSA site in Indiana as well as one in Kentucky. And then most recently, we just passed our CMS DME accreditation, which allows us to now get contracted with other entities outside of the state. So we are contracted with Indiana Medicaid and are now working on credentialing and contracting with other states throughout the Midwest as well as the South. Next slide. So how does Navigate work? So it's very simple. We get contracted with those payers, and then from there, physicians are able to prescribe our solution. Our devices they all have the three key components of reimbursement: coding, coverage, and payment. So mom does not pay out of pocket for our devices. They're currently covered. The doctor submits an order form. That order form comes back to us here at Navigate Maternity, and we take care of the rest. Our technology also is our Navigate Pro and our Navigate Her. It does integrate into an EHR. Actually, our back end is an ONC certified EHR. From there, mom is able to track her data, and then she's able to share that data with her care team, or even be able to have that data at her next appointment to be able to be empowered with that so that she can advocate for herself. Again, we also support with lactation, breast pumps, compression garments. Next slide. And so these are the states that we are going live. You'll see that we have California, and then obviously some states, Texas and Oklahoma and Louisiana. But we've really focused in, as we call, kind of the middle of the country. We're based in Indiana, so we're based in the Midwest, and this expansion will really focus on the Midwest and the South. Next slide. And we were recently featured back in Forbes this past February. We were in the American Heart Association's Empowered to Serve Accelerator back in 23. They highlighted our work just a few months ago, which was really exciting. And McKinsey did a Black maternal health report and named Navigate Maternity as one of the solutions that they identified as being something that can help to solve this crisis. Next slide. These are some of the other accelerators and competitions that we've won over the years, but this is my final ask. Next slide. Can I count on you all to join us, collaborate alongside with us so that we can impact maternal health, rural maternal health, and end this crisis? Thank you so much.
Thank you, Ariana, for all of your work to support innovations in maternal health space. Now that we understand the challenges before us, we want to hear from Elizabeth Wallace of the Mobile Healthcare Association about the solutions being advanced to address the gaps that we have discussed today and help rural communities nationwide. Elizabeth, you're on mute.
Hello there. Thank you very much. You can move to the next slide. I'm honored to represent the Mobile Healthcare Association, the nation's largest professional society for mobile health clinic professionals, uniting nurses, physicians, dentists, public health officials, and other providers who bring care directly to underserved communities. The Mobile Healthcare Association emerged really from a grassroots movement to close gaps in healthcare access that traditional models could not reach. Through connection and education and advocacy, the association strengthens the mobile health workforce, advances best practices, and drives innovation. We're united by a simple commitment, bringing timely, quality, and patient-centered healthcare directly to people where it is needed most. Next slide. Nationally, more than 82% of mobile clinics serve rural areas, reflecting a critical focus on communities that are medically underserved or considered health professional shortage areas. These mobile programs break down distance barriers and help stabilize access in regions where rural hospital closures and provider shortages are an ongoing crisis. National studies by the Mobile Health Map at Harvard Medical School confirm that mobile health clinic models return between 3-to-1 and 15-to-1 in value by doing a variety of things, including reducing preventable emergency room visits, increasing chronic disease management, and catching early stage conditions before they become costly crises. By forging partnerships with local hospitals, public health agencies, and federally qualified health centers, mobile teams can connect women to insurance, ongoing care, and social supports while keeping costs contained. Next slide. Mobile clinics are uniquely positioned to serve rural America, where over 60 million people live, but only a fraction of physicians practice. As we know, rural families often face transportation, workforce, and facility shortages that limit access to care. And here are mobile clinics to provide quality, culturally responsive care in a convenient setting, often reducing time away from work while building trust with that community. Next slide. These professionals reach deeply into rural, tribal, and historically underserved communities. They're closing gaps where many residents face a scarcity of providers and significant travel barriers. Mobile focuses on the whole person, from newborns to the elderly, addressing food insecurity and other social determinants of health, as mentioned earlier, alongside providing preventative care and screenings, health education, important mental health services, and ongoing care for chronic conditions. I want to highlight the University of Arizona's mobile healthcare program, which last year provided care to over 500 patients. They mentored 21 medical students and documented a preterm birth rate of less than 3%, a fraction of the national average of 10.4%. Mobile programs demonstrate scalable, replicable results, increased Medicaid enrollment for previously uninsured women, lower cardiovascular risk, and critical mentoring for next generation clinicians. I want to share a quick patient story from the Arizona mobile program. Grace, a woman of color, established care with the mobile program in 2020 during her first pregnancy. The team provided comprehensive prenatal and postpartum care, and she delivered her baby vaginally at the hospital. The mobile team continued to support her through breastfeeding and continued care. Grace reaffirmed the trust that had been built when she and her husband returned to the mobile health clinic in 2022 for her second pregnancy. But this pregnancy was more complex due to gestational diabetes. Because of this diagnosis, she needed frequent monitoring in late pregnancy, including weekly non-stress tests and third trimester fetal growth ultrasounds. The mobile clinic was able to meet her needs by providing a home glucose monitor, as well as performing non-stress tests and ultrasounds right on site. With close monitoring and support, Grace successfully managed her gestational diabetes and delivered vaginally. Her postpartum course was complicated by a kidney infection, which was treated and then followed closely through the mobile health clinic after discharge. Unfortunately, women like Grace often face fragmented, costly, and inconsistent care. But instead, through the mobile program, she receives seamless, holistic support that honors both her medical and emotional well-being. And her 2 healthy children receive ongoing care in the mobile program's family medicine clinic. Next slide. Mobile clinics provide essential care to vulnerable populations on Medicaid, uninsured or underinsured individuals, continuing to demonstrate their commitment to serving people who would otherwise go without care. So you can see more than 41% of mobile clinic patients rely on Medicaid and Medicare, and even more lack insurance, highlighting the critical safety net function mobile health delivers nationwide. The continued closing of rural hospitals has significantly impacted travel time for outpatient visits, resulting in median travel times at 55 to 70 minutes for most rural patients, according to the Journal of Rural Health. And in some remote areas, travel times is 90 to 120 minutes. But here's the good news. A study on travel times of mobile health clinics mapped in Connecticut found that 90% of the patients live within 5 miles of a mobile site, and the mean utilization was highest among those living 11 to 20 miles. This holds true nationwide. Next slide. Unacceptably, 2.5 million women live in counties with no obstetric clinician, and more than 6 million women of reproductive age and 1 in 10 babies live in counties where there are no hospital obstetric services. For Native and rural communities, travel times to care often exceeds double the national average. These deserts are also marked by higher rates of chronic illness and risk factors, including hypertension, diabetes, and tobacco use. The mobile health map has shown through national data that mobile clinics provide hundreds of thousands of visits per year and produce positive outcomes for populations who otherwise fall between the cracks. Since 2021, visits to mobile units have increased 33% through the March of Dimes mom and baby mobile health centers in communities across the country. In these programs, nearly 70% of visits are with uninsured or underinsured patients, a vital lifeline. Postpartum, prenatal, and well women and well child visits are delivered consistently, minimizing missed appointments and improved outcomes. One of our members, the Ohio Health Wellness on Wheels, or WOW Mobile, is a March of Dimes partner and has demonstrated measurable reductions in infant mortality across central Ohio. They provide comprehensive data-tracked prenatal and postpartum care directly within high-risk neighborhoods. In a long study between 1994 and 2023, the infant mortality rate among the WOW patients was 5.4 deaths per 1,000 live births, compared to Ohio's average of 7.1. There's evidence-based documentation shows that consistent, localized prenatal care delivered via mobile clinics materially lowers infant mortality in historically underserved areas of Ohio. Next slide. Trust remains the defining feature of mobile health innovation. The Harvard Family Van program, often cited as a national model, uses what's termed the knowledgeable neighbor model, building long-term community relationships to improve chronic disease detection, self-management, and adherence. These models often include community health workers, which are covered by insurance in Massachusetts, but not everywhere in this country, and social service navigators embedded within mobile teams, linking patients with food, housing, and behavioral health supports. These mobile clinics are structured as flexible community-anchored systems, deploying where population health data shows the greatest gap. Routes are often determined by real-time need assessments and community input, ensuring culturally competent, locally trusted care. Next slide. A 2024 Harvey L. Neiman Health Policy Institute study on 2.6 million women found that mobile mammography has the highest uptake among rural, non-white, and lower income communities. Research confirms, most importantly, that mobile clinic does not substitute for facility-based screenings, but supplements it, reaching women who would otherwise not have been screened. This is especially pronounced, as you can imagine, in rural and low-income areas, among racial and ethnic minorities and uninsured populations. One recent study found that American Indian and Alaskan Native women were 450% more likely to use mobile mammography than whites, while women in rural communities were 210% more likely than their urban peers. The members of the Mobile Healthcare Association who do mobile mammography see this as a critical strategy for expanding breast cancer screening. These programs reach underserved communities by partnering with community organizations, employers, and faith-based groups for accessible events. I'd like to share a story of a 42-year-old Latina woman from New York who approached the Stony Brook Medical Center van as it was packing up for the day. She said that she'd walked the van from quite a distance, did not have an appointment, nor insurance. The team on the mobile mammography unit stopped packing up their gear, called and got her registered, and performed the screening mammogram. Can you imagine that happening at your doctor's office if you showed up after they were closing without an appointment? The mammogram and follow-up diagnostic screenings confirm breast cancer, and thanks to the early interventions and connection to treatment, she is doing well today. Last slide. In closing, mobile clinics are more than vehicles. They are engines of innovation and equity, trusted partners in the communities they serve, and a proven model for transforming access to care for women from all backgrounds. Thank you for your commitment and partnership in advancing these vital solutions.
Thank you, Elizabeth, for helping us understand how we can take action and drive change now. As our speakers come back on, I actually just want to say that it's clear that healthier women leads to healthier families and healthier communities and a healthier nation. I think I've been saying that for decades. We must improve. As you've heard today, there are urgent healthcare challenges facing women in rural communities, and innovative solutions are needed to improve access and outcomes. We must improve healthcare infrastructure to our rural communities and counties. Federally funded initiatives should increase the number of rural health clinics and mobile health offerings for women's health services, including maternity services, and strengthen our rural health care workforce. We also obviously need to expand improved care to telehealth, broadband, and flexible service delivery models that ensure reimbursement and parity for these services. And clearly, postpartum coverage is essential to the improving of continuity of care. So while I have just said all that, and you can read it, I actually want to turn to one of the questions that has come in about what can we do to recruit more healthcare providers in rural areas of America. Elizabeth or Ariana, I'm going to turn to you first, one of you. Or actually, who would like to take it?
Well, I'm just going to say, I'm going to say that, we know that staffing in the medical field right now, since the pandemic, is a crisis throughout our country. But I think the understanding of building up the workforce from within the community, so taking medical assistants, and there are programs that are allowing them to then continue their training. And so continuing to serve the communities from which you were raised.
We also have many nurse practitioner education models that circle around community-based training. So allowing students to do practicum experiences with providers in their own communities helps keep people in the community. And we also, in rural states like West Virginia, our medical schools have programs where all types of interprofessional providers have experiences in community centers to help encourage them to remain in the communities where they're from and where they want to serve.
Right.
And so I think involving the community in that is really important, and having experiences in community to see what it is. It has its disadvantages. I had one student tell me once they wouldn't work in a rural community because there's no Starbucks. I mean, so everybody has their own priority, but others, like the two nurses who run the mobile unit down in Wise County, West Virginia, the nurse practitioners there, started that basically to say and to continue to provide service to their community, because them and the physicians they work with and other providers were committed to that community. And if we can build that sense of community, I think we could get other providers interested.
So we are running up on time, but I want to say two things. One is we recognize there are questions in both the chat and the Q&A. We are capturing those, and we will seek to try and answer to those of you, since we are running now short on time. But I do want to ask one more question, because there are hundreds of innovative companies that are offering solutions that could help improve access and outcomes for rural Americans. So how do we help those companies more? I guess I recognize federal funding would be lovely, but it's a little complicated, it feels like right now. So I'd love to hear perhaps Christine or from someone, what would you say to that question? How do we help those innovative, you guys, how do we help you?
I'll hop in here. I think one of the ways that we can help with innovation, especially in women's health, is whether we are the decision making decision maker or not, excuse me, we can help advocate for better funding in women's health. I think that is really the key to success. In order for us to bring more of these products to market, we have to have the appropriate funding structures. We've seen some really big changes with SBIR, which was one of the main ways that we were able to access funding for early stage companies. Non-dilutive funding, and many of those awards have been stopped. And that's the lifeline of women's health. VCs, all of those different levers that help to fund women's health are important. And then secondly, the other piece is reimbursement, right? Reimbursement is how we have sustainable ways, whether it be a provider, whether it be a innovation. This is how we sustainably bring value and innovation to this patient population. We have to have sustainable reimbursement structures that allow physicians to take care of their patients, that allow med device companies to serve patients.
Sadly, I would love to keep this conversation going, but as someone has said, unfortunately, we are running up on time, but I want to say that someone has said in the chat, and I totally believe this, that, she says, how can we empower women in rural areas with technology so they can be more engaged in their care? Because she believes very much in the agency of women. And I thought that was a beautiful statement, which I wanted to share with all of you, because I'm looking at all these different boxes right here. And that warms I do feel that. I feel that very strongly, which is that women are the champions of our healthcare. I would like to thank everyone who's participating in Healthy Women's Rural Health Briefing today, and for your commitment to learning and taking action. I especially want to thank our speakers, Christine Hamp and Joyce Knestrick, Ariana McGee, and Elizabeth Wallace, for providing us with such invaluable information about the challenges facing women and their families in accessing healthcare in rural America. And my last thank you is to our Corporate Advisory Council members for being willing to invest in the health of all women. It is because of you that we are able to continue to advance women's health. Thank you, everyone.